Hello everyone, and welcome to today's webinar, 5 Ways to Improve Revenue Cycle. My name is Alex Goulding. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer speaker system by default. If you'd prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A portion of today's session. Also, please note that the slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. I would now like to introduce Darren Bibb. Prior to joining iHealth in 2015, Darren was the president of Paradigm Management Solutions for 19 years, managing approximately $60 million in annual healthcare revenues and providing practice management consulting and management services to a wide range of specialty practices. He has been on the faculty of the University of Louisville for 17 years, where he created and teaches the Residence Practice Management curriculum. Darren is a member of the advisory board for Citizens Union Bank in Elizabethtown, Kentucky, on the board of directors for StepWorks Recovery Centers, and a board member of the Kentucky Pediatric Society Foundation. His professional organizations include MGMA, KMGMA, HFMA, KHFMA, and HBMA. With that, let me turn today's presentation over to you, Darren.
Thank you, Alex. I appreciate that introduction. As we enter a new phase of healthcare, there's a lot of change coming. And you've heard all the new acronyms, MACRA, MIPS, APMs, etc. But one thing has yet to change, and that is the accounts receivable management process. So what I'd like to do today is talk through 5 elements, 5 issues, 5 items that are as important now as ever in today's healthcare/practice management. So from an agenda standpoint, there are 5 items. Evaluate all aspects of current billing process. I'm going to talk more about all being the operative word there. Number 2, evaluate accuracy of provider credentialing statuses. Credentialing has become a much bigger issue, so we'll talk in detail about that. Number 3, evaluate and tighten the encounter or charge capture process. Number 4, critically evaluate the intake process, and critically is an operative word there. And then number 5, take a systematic approach to working accounts receivable. So those are the 5 topic areas. So I'd like to take each one of those and dive into those in more detail. Number 1, evaluate all aspects of the current billing process. We work with a lot of different specialties, and we work with a lot of different sides of practices. And so one thing that I see consistently is as an opportunity, some people say it a failure point, but I look at it as an opportunity, is that no one takes ownership. No one person takes ownership of the complete process or the complete results for a particular, and we'll use account, payer, or physician, and that really depends on the size of the practice. If you're in a 1-doctor practice, then it's 1 physician, so one person has to take complete ownership of that entire billing process. One of the things as you get into a larger practice we see is that there's not a clear understanding or expectation of the billing process based on a payer mix. And so what ends up happening is, and this is regardless of the size, is that different payer mixes, different payers are treated differently. Different payers pay differently. And so it's not there's no clear expectation as to, based on a payer, what should happen. And when I say that, I mean literally, what are the metrics for that payer? Establish a baseline. So if it's Medicare as the payer, then based on our fee schedule, we should expect X dollars on average coming in per dollar of charge. We should expect that our accounts receivable ratio is X for Medicare. And so not just in a vacuum select those or define those expectations, but actually track them on a month-to-month basis. And I can probably hear some of you saying, great, that's just something else we've got to do, something else we've got to track. Yes, but these are fairly simple calculations. And if you're lucky enough to have a dashboard system, then it makes it easier. But even in a manual sense, it's difficult to define success if we don't know what the expectations are. So look at things on a payer mix basis. Another item is know your contracted payers. I mean, literally know who you're contracted with. And this tends to become an issue as the practice gets larger. And in today's healthcare, there are many wraparound networks and hidden networks, and you may think you're contracted with payer XYZ, and you are for 3 plans, but not the 4th and 5th plans. And so, yes, it's a difficult job, but again, if you don't know your contracted payers, your accounts receivable will suffer. Not to mention the impact on the patient when they find out that you're not actually in their network. The next one sounds simple: automate processes wherever possible. And this literally takes people stepping back from what they've done or what you've done or what you're trying to manage. Step back and count the manual touches. Count how many times a human being is touching something along the way in the billing process. Change is tough. Change is very hard. But there are automations out there that it can improve the process. And I say this somewhat jokingly because I would still love to have a BlackBerry if I could. But there are newer and better technologies that have come along since then that have made me more efficient. So automate wherever you can. Understand that if you can if you can eliminate a person touching an EOB and automate that process in some way, you benefit. Now, again, you have to have controls around that, but there are ways to improve. Lockboxes are a good example. Some people have had great success. Some people don't like them. They can be expensive. So again, it has to be size specific, but a lockbox is a great example. And I say lockbox, literally a lockbox for all payments, as well as there are now options for patient payments, which are sort of like a lockbox, but it's specific to patient payments. And that really leads into the next one, the next two, actually the next three, which is make patient payments simple. If any of you all have been a patient, you've experienced what I'm describing. Some practices make it extremely simple for you to pay your bill. Others make it a labyrinth. And we work with physicians and practices that are all over the map. Some, it is make it so incredibly simple that they don't have a reason not to pay, except for they don't have the money. Others, it's we don't take credit cards. You have to mail in the payment, which is a check, which is touches, and it really does affect their accounts receivable at the end of the day. I mean, we manage the receivables for them, and I can show you statistically the ones where they have made the process simple and the ones that don't make the process simple, just in terms of patient accounts receivable balances per doctor. And so that's where you get to the next one, review options for patients to pay. I mean, again, you do something for long enough, you tend to get in that routine. You have to step back at some point and say, what are our options for allowing patients to pay? And do we need to reevaluate those? And sometimes it's a very simple yes. And that can be digital wallets. For years, people said, oh, you don't dare want to keep credit card information on the patient. And I understand why. But most transactions that people make now, their credit card is somewhere in the cloud, with whether it's Amazon or some other cloud-based vendor. So again, with proper security, make it easy for the patients to pay. And the next one should sound obvious, but it sometimes is difficult when you're so busy doing what you do. But create a customer-friendly, positive environment. And sometimes it's just how you say what you say. patients don't typically understand health care, and especially their insurance, so we have to know it better than they do, and then we have to create an environment as customer-friendly as we can to help them want to pay. And then the last one, and this is an entire session on its own, is you have to step back, step out of what you're doing and look at the workflow and the potential impact for value-based reimbursement models. And nobody really knows yet. I mean, there are a few out there that have already jumped into some value-based reimbursement, but very few. And so we're learning every day what this is going to mean. And when you find out what it's going to mean to your practice, you have to then step back and say, okay, how is this going to change my billing process? The next item is evaluating the accuracy of provider credentialing information. And this, it's a very simple thing to say, keep the provider enrollment information up to date. And sometimes that's hard because if the person doing or the people doing the billing are also doing the credentialing or the provider enrollment, it can be an afterthought, and you don't know it's a problem until it's a problem, and then you spend a lot of time working backwards. We have people that come to us and they actually have us do the credentialing for them on a regular basis, actually maintain it for them so that they don't have to worry about it, and we work hand in glove with them. In a typical practice, though, the person doing the credentialing may not always keep it up to date. And I got a call yesterday from a person who's got a Medicare problem. And it's a Medicare provider number problem in the PICO system. So keeping that up to date is sort of mission number one. And then, and this is critical step, is feeding that information to the intake staff regularly too. Because there may be things happening on the backside that the credentialing / provider enrollment / billing people find out that actually impact the intake process. And sometimes it's difficult to get, especially if you're in a larger organization, potentially where the billing department, if you will, is not even on site where the patients are being seen. Sometimes it's difficult to get that information back to the intake staff, but it's a critical step. And then the next one, makes certain staff are knowledgeable about payer enrollment requirements. That's a two-step process. One is the staff, whoever is managing the credentialing process, has to understand the enrollment requirements. We routinely get calls from physicians and practices that, well, they say, well, but 5 years ago when we enrolled Dr. Smith, we didn't have to do this. Right. Well, it's been 5 years and Medicare changed their rules several times. Well, we'll get a call. We didn't know to do that on this. We didn't know that for the nurse practitioner that we needed to have these two additional elements of information. Right. And I'm not saying it's easy, but you do need to know prior to starting the process what requirements are in place at that point, which leads to the next one, which is, and again, this takes time, but you need to anticipate issues when adding new providers. We work with a lot of practices that have turnover within their physician or extender ranks, and so every time somebody turns over, every time there's a new provider in the practice, it's always a struggle to get them to understand, one, there's a timing issue, two, getting that provider to understand that response to us or to a practice person who's doing this is critical before the process even starts. And so if you can anticipate, if you know you're going to add a provider in 4 months, then you really need to push the process to get the demographic data, form signed, etc., in the next 30 days so that you can then begin the process for enrolling that person. The next critical element is evaluate and tighten the encounter or charge capture process. This should sound simple. I mean, we all want to get, the physicians want to get paid. You want the physicians to get paid so that you can get paid. I mean, it should be a simple thing, but depending upon your specialty, depending upon where the service is actually rendered, EMRs were supposed to fix this issue, which I found that ironic even as they were being introduced, because really EMRs are good at capturing charge information in an outpatient setting. But if any of you are working or have physicians or providers that work in an inpatient setting, that doesn't really do you any good from a charge capture process perspective. So again, step out of it, step back from the process, evaluate it, and try to simplify if at all possible, understanding that you're only as good as the physician or the provider will allow you to be. But there are ways to reduce, and this is where some automation can help. And that's where you constantly have to continue. We looked at that 5 years ago. Well, you need to look at it again, because in 5 years, there's a lot of technology that's changed. So look at it again. And that's the next one. Use technology wherever it's available. It's not always simple, and sometimes you can use technology, and yeah, it can make mistakes, but continue to evaluate those, because if you can take, again, go back to the human touches. If you can take human touches out, that's time, and that's what I'm after. Because remember, we're all after a shrinking dollar. Payers rarely call you and say, guess what, we're going to increase your fees 5% this year. Now, some of you all may have had that Christmas gift. I haven't worked with many that have, though. Next item is reconcile to the source. If you have a physician or provider, regardless of where it is, if you have, if they're turning 30, they're having 30 encounters at a facility in a day, what is the source document they're giving you from which you would then extract charge information, whether it's CPT or ICD or whatever? That becomes your source document. Or is it the rounding slip at the hospital? So you need to define what's my source document. Then you reconcile to what you post. Sounds simple, but many people miss this. We've had examples recently of a hospitalist group, and something just didn't feel right, just didn't seem right. And so we asked them, we said, well, how do you reconcile? And they have the source document, but they weren't reconciling the source document with what they posted in their system. And so they missed 4 encounters in a month. And you think, well, that's a big deal, right? 4 encounters, no big deal. Well, that's 48 per year. Do the math on the average reimbursement. Let's say it's $80, $3,800 a year. Okay, is that really a big deal if you're typically collecting $350,000 a year? Well, guess what? That's a 1% loss. That's a 1% loss that was controllable but not controlled. And if you have a bigger practice, imagine how you just extrapolate that. If you've got 5 hospitalists instead of 1, then 5 times, before you know it, you're starting to capture money that maybe it was lost last year, maybe it's newfound money. But then again, maybe it's just we're keeping it from getting lost so that next year when Blue Cross hits us with another reduction or Medicare tweaks the code here and there, it's not as bad an impact. And this last one, we probably all can say yes, this is a simple thing to say, evaluating and improving the provider physician coding. But I do see routinely where it's like 2 islands. You have the physician providers doing their thing, and you have the billing division doing their thing. And the billing division has information that's important that never gets back to the physician so that they can change their behavior. And sometimes it's not even as obvious as, well, this code is not a valid code. Sometimes it's in the documentation. Sometimes it's, hey, I'm getting rejections back here on the backside because of documentation that's not there or should be there or wasn't clear enough or wasn't elaborate enough. So just literally walking it back to the physician provider and saying these are the things that would be helpful that we're getting denials on, that would be critical. And the providers saying, wow, that's great, I never knew that. Now, admittedly, sometimes you may have to tell them 4 or 5 times, but that's part of the job, is just continuing to remind them or help them in some way, whether it's some sort of template that they could dictate off of, or some sort of coding cheat sheet that just says these are the elements I have to include to make sure that I'm documenting the level of service I'm billing. I've had people ask me, well, what would be appropriate in terms of documentation and denials? And we tend to think if you did an audit of the documentation for the codes billed, if it's not at 95% or above, you really need, and it may be an outside party coming in saying, let me look at your documentation and let me help educate you, because anything below 90%, if Medicare were to come in and review, then you may have a problem. And if you can do one internally and score greater than 95%, good for you. The next one is critically evaluate the intake process, and this one we could probably spend a great deal of time on, because, and I've done this for 20 years plus a couple maybe, and it's really been in the last 5 years, even the last 10 years, if you really look back, that the role of the front desk has changed dramatically. It is, in reality, what's happened is that processes in the back, processes that used to be managed after the fact in the billing department, in the billing office, somewhere in the basement or the upstairs, it has been moved to the front. And there are still practices out there that have not made that transition. And sometimes it's, I don't know how. Sometimes it's difficult from a physical plant standpoint to adjust. Sometimes you're going so fast all the time that you can't stop and think about what has to change and then actually implement those changes. And the way I think about it is you really have moved a portion of both we think patient receivables, but you really have moved a portion of patient receivables as well as insurance receivables to the front. So now what you're trying to do is you're trying to eliminate back-end denials. You're trying to eliminate patient receivables on the backside, because it's getting harder and harder to collect that money. And there are macro issues that have impacted this. 2014, when Obamacare took place, and you had all of these, set aside Medicaid for a second. These are commercially insured patients that on December 31st, 2013, had a $1,500 deductible, and on January 1st, 2014, had a $5,000 deductible, a $7,000 deductible, $10,000. And so suddenly, their responsibility ramped up. Most practices didn't flip a switch overnight and move more of that process to the front. Why? Because the phone's ringing, they're making appointments, they're checking people in. So the role there really needed to change, and some have successfully, where they're doing more financial counseling. They're doing more financial counseling than ever. Well, guess what? That's typically not a billing person. That's typically not an AR person. That's typically a receptionist. And so you do have to make the time commitment to evaluate, what is that person doing? What level of knowledge do they have? What level of skill do they have? Do they have enough time? I mean, think about the typical check-in, the way it used to be, and how fairly simple that was, and the way it really needs to happen now. And that you have to have time. They have to have time to sit and talk to people. They have to have a knowledge of the insurance plan that patient has. And so your skill set really does change. Then you change, the billing or management have to change your expectations for time of service patients or payments. You have to decide, okay, we really need to be collecting 98% of what we can collect at the time of service, and then measure it. And again, that's something else you may need to have. If you're lucky enough to have a dashboard, great. If you don't, you just need to keep it and compare it every month. It may be different operators. It may be one operator does a very good job, and then one operator just is not comfortable asking for money. Because again, you got to remember, the skill set historically at that position is not necessarily the skill set of a billing person and the knowledge that comes along with that. In addition to that, you have to think about referrals. If you're specialty practice, referrals in. If you're primary care practice, referrals out. Pre-authorizations out. Pre-certifications for services for your patients. Who does that? Where do they do that? When do they do that? If it's at that point, then again, you need to critically look at that entire process. And the size of the practice will determine the number of bodies and FTEs that you have for these different processes. But think about it in terms of whatever I do, however I change, I have to try to measure success. So what are my denials right now? What are my denials right now for no referral, for no pre-authorization, for no pre-certification? And my goal really should be less than 2%. That is a reasonable expectation. If you're at 5%, great, you've got something to work towards. And then you can measure that, but do measure it. And I guess lastly, this sounds simple, a systematic approach to working AR. How else would you do it, Darren? I don't understand. It seems so simple. Well, this gets back to that very first item. Some one person has to take responsibility, has to take ownership of the AR. And first thing is establishing expectations on a per operator or per staff basis. If you don't have expectations, how do you know if you're ever going to get there? And part of that can be implementing, statistically, there's metrics for that. We've talked about several of those throughout the presentation, but don't underestimate the power of a very quick 15 to 20 minute weekly education session where you or somebody else leads it. And this is not a social time. This is not a bitch session. This is not a we're going to save the world. This is literally 15 to 20 minutes should get you what happened last week, what's coming up this week. Medicare's changing this. Blue Cross changed that. We found out that XYZ insurance company is we're no longer in their network. Simple things that are relevant to everybody, and if you can spread the information that way, where if it's in a bigger practice, but it would be ideal to include your intake people in that as well. And that gets back to educating. Critical too is your denials. It's just managing your denials. Categorize the denials, track the denials, report the denials. And I don't mean a fancy, elaborate spreadsheet. I mean, if you've got a dashboard, great. If you don't, a simple spreadsheet. You need to know, where are we losing money? Where are we not getting paid and why? And that's your denials. And a lot of practices, I find it still ironic that a lot of practices do not post the denials. Well, if I don't post the denials in my system, and I know that takes time, why do I need to post something if it's denied? Well, because I can track it in the system. And plus, if my next operator comes in and looks at the account, they'll see, hey, that claim's already been denied. So yes, it's an extra step, but it's also something that can be reported. It also helps, if we're looking at it, it helps us figure out what's the root cause. I mean, is it a particular payer that's having an issue? Is it a particular Medicaid MCO that's causing the problem? Well, then maybe we just need to deal with that Medicaid MCO, and maybe the rest are normal or according to expectations. Then use a dashboard for your key accounts receivable metrics. Think about, okay, collection rate's an obvious one, but AR ratio, which is the time on average it takes to turn around a claim. AR aging, that's kind of obvious, the different buckets. And then adjustment ratios, and that's another something that people tend to not look at. Is just, what are we adjusting and why? And you need to do this by payer, because as a whole, that's good information, but it really doesn't tell me if I've got it. It masks a particular problem with a payer if I'm only looking at the metrics for the practice or the physician as a whole. So look at it by payer. And again, do this every month. Track these. These are simple statistics to calculate. They are they're based on information that comes out of your system at the end of the month, but do it by payer. And then the next one sort of gets back to one of the first ones, which is you've got to constantly train and retrain. And with the turnover rate in a lot of practices, this is an ongoing issue already. So it's hard. Yes, it's hard, but you have to do it. And then lastly is what we call co-sourcing, which we're seeing more of this because some people don't want to give up total control of their revenue cycle. But if you're a big practice and you've got a denials problem, or you've got a particular specialty that you're struggling with because you just don't have the expertise or the people, then we're seeing people call us and say, hey, can we co-source? Can we outsource certain parts of it? Which actually we've been seeing this for a couple of years now, and it actually does make sense. You've got to be very particular about about what you're outsourcing, and you've got to be very particular about expectations. But it is it's a potential option. So that's hopefully some insights, some metrics that you can track. Hopefully that's giving you some ideas that if you're looking at AR ratio, that's a one to start with. Okay, where are we? Well, we're at 65 days. Well, where should we be? We should be at 42 based on our specialty. Right there, you've got opportunity, and then you start drilling down into what are the things that are causing us to have that spread, that negative spread. So those are hopefully some helpful ideas, and I appreciate the opportunity to talk to you guys today.
We are at the top of the hour, so out of respect for everyone's time, I'll go ahead and conclude today's session. Thank you, Darren, and thank you to everyone for taking the time to attend today's webinar, 5 Ways to Improve Revenue Cycle. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate if you'd complete that and provide your feedback. As a reminder, today's slides will be shared in a follow-up email within 24 to 48 hours, and we will also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenter, thank you for joining us today, and have a great rest of your day.